Hey everyone, this is Angry Bill with Pre-Hospital Wisdom. I'm here to talk about the differentiation of wide complex tachycardias. It's a skill that a lot of paramedics spend a lot of time on, and so I'm going to work through all the rules behind it and how it ends up working and how it all works. Stay tuned until the end where I actually give you my one secret trick to pull this all together and make it make sense. So let's start with a scenario. You're dispatched to the report of a sick case. When you arrive, you find a 52-year-old male patient only complaining of palpitations. When pressed, he complains of very mild chest discomfort that he refuses to describe as pain, that he rates about a 2 on a 0 to 10 scale, but the palpitations are his biggest problem. He has an irregular pulse of 130, a blood pressure of 116/70, and a respiratory rate of 16. He's warm, pink, and dry in oriented times 4 with humor, which I always think is a extra additional thing. You can know what day of the week it is and what's going on, but once you're cracking jokes at the situation, that's an especially clear mentation. So this is the EKG you get from him. Go ahead and pause, take a look at it, and think about what you think is going on here, about what you think this is. There's some people that'll say it's probably not VTAC because he's got such great vital signs and he's completely awake with humor. And there's other people that say, well, the left bundle branch block pattern and the blah, 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 blah. Let's not worry about that. Let's think about a different scenario. This one's shorter. This EKG is from a 72-year-old male complaining of chest pain. He's got a blood pressure 130/70. Now, I know this is an old EKG, and so it's not especially pretty or whatever, but you can see kind of what's going on. You can see all 12 leads, and so go ahead and pause and think about what's going on here. So, what we end up talking about is what is causing this wide complex tachycardia. This is regular wide complex tachycardia, which can be one of 10 things. Number 1 is VTAC. Number 2 is a VTAC, 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 VTAC. The first 8 on our list of 10 is VTAC. 80% of the time, a regular wide complex tachycardia is going to be VTAC. And I actually think it's probably even a little bit higher than that. It's rare in medicine for something to come out as 80% this, 10% this, and 10% this. So just saying, I bet it's more than 80%. The last 2 are supraventricular tachycardia from whatever origin with a pre-existing right or pre-existing bundle branch block, either right or left bundle branch block, or supraventricular tachycardia from whatever origin with what we call aberrant conduction. And when we talk about aberrant conduction, what we're talking about is, for example, Wolff-Parkinson-White is altering the conduction, or hyperkalemia is altering the conduction, or the rate is altering the conduction. With rate-dependent bundle branch blocks, what's going on is that one of the bundle branches can repolarize, but one of the other ones can't due to the rate. It doesn't have enough time to repolarize. So by the time that next impulse, that next beat is coming through, there's essentially a physiologic bundle branch block. It's not due to the bundle branch being blocked, it's due to the repolarization of that bundle branch was incomplete. So most of those cases end up looking like one of the bundle branch blocks. So essentially we're talking about VTAC versus SVT with the bundle branch block. Both of those can cause wide complex rhythms. So when we start thinking about differentiating between what's going on, one of the things I want you to keep in mind is you're not starting on the fence trying to decide whether to jump into the supraventricular yard or the VTAC yard. You're starting in the VTAC yard. You're starting over there. 80% of the time, it's going to be VTAC. So don't start on the fence. Essentially, you're starting with VTAC and looking for reasons to climb a fence and to get into a different yard. So if you start with that, you're going to be much better from a starting point. So let's begin with this, going back to 1991. Brugada et al. published an algorithm in 1991, shown here, that works through different morphologic findings, different findings in the EKG to decide whether this is VTach or SVT with a bundle branch block. And I like this algorithm a lot because it's got sensitivity and specificity findings associated with it. In the end, down at the bottom there, the fourth box with the on the left side is morphology criteria for VTach present in both precordial leads V1 and V6. And so Brugada's morphology criteria is listed right here. And so this is both fairly complex. And so what I've done is I've taken this and work it back through this chart. And this is what I use to teach paramedic students about the differentiation of wide complex tachs. So one of the things to understand about this chart that's going to be really important is that there's a whole lot of waffle words on here, and B, anything not on the list doesn't help you. So for example, a heart rate greater than 250 favors a ventricular origin. Or I'm sorry, a heart rate greater than 250 favors a supraventricular origin. So for example, a heart rate greater than 250 favors a supraventricular origin. A heart rate between 100 and 250 or 120 and 250 isn't on this list. It can be either. Same thing with the axis. A right shoulder axis favors a ventricular origin, and that makes sense. As the heart depolarizes from the bottom up, it's heading towards the right shoulder. That means it started down lower and is heading in that direction. Right shoulder axis makes sense. So that's probably favoring a ventricular origin. Same thing with really superior axis. Starting at the bottom and moving up, even if it's not quite right shoulder axis, but it favors a really superior left axis, that favors a ventricular origin. What about normal axis? Normal axis isn't on this list. Normal axis can be either. Right axis can be either. So make sure to apply this list correctly. And as we work through this, every one of these findings needs to be memorized and recallable to you at 3 in the morning when you're on your 28th call, you're hungry, you don't want to be there, you just got woken up out of a dead sleep, whatever else your problems are, you have to be able to recall this really, really fast, okay? So in V1 and in V1 only, a taller left rabbit ear favors a ventricular origin. What we're talking about is an R prime or an R with a slur on it, where the left rabbit ear is the taller version, or is the taller waveform compared to the right. That favors a ventricular origin. Notice that the taller right rabbit ear isn't on the supraventricular side. What we're looking for on the supraventricular side in V1 is that stereotypical RS-R prime pattern, right? The triphasic right bundle branch block pattern where the S wave is below the baseline. If it looks like an old friend, if it looks like every sinus with a right bundle branch block, that QRS looks like these QRSs, then yeah, it might favor a supraventricular origin. But for the most part, how often does that happen? A single symmetric peak in V1 favors a ventricular origin as well. Considering downward QRSs in V1, a fat initial R wave, so a small R, big S, looks like a left bundle branch block pattern in V1. But if that small R is wide enough where you could fit a small box in it, it's greater than 0.04 wide, that fat initial R wave favors a ventricular origin. The same thing, if you're missing an R wave and just have a QS pattern in V1, a slurred downstroke to a quick upstroke favors a ventricular origin. A supraventricular origin, like a left bundle branch block, probably has a narrow R wave or a steep downstroke with a slurred upstroke. In V6, an RS pattern or a QS pattern, predominantly negative in V6, favors a ventricular origin. And if that S wave of the RS or the QS is greater than 15 millimeters, it also favors a ventricular origin. On the supraventricular side in V6, if you have a narrow, tiny Q, big, tall, narrow R wave, followed by the slurred S wave in V6, that fits a right bundle branch block pattern, right? What we're talking about for a right bundle branch block pattern is a tight, narrow Q, tight, narrow R, fat, slurred S wave. That favors a right bundle branch block pattern. So that might be supraventricular. Moving on to the general limb leads. We already talked about the superior axis or the right shoulder axis favoring a ventricular origin. VTAC also can present with fusion beats or capture beats. AV dissociation can show that it's VTAC. Or in AVR, an initial R wave. The initial waveform of the QRS is upright. In AVR, it favors a ventricular origin. Rates faster than 250 are usually related to Wolff-Parkinson-White repolarization. What we're talking about there is an antidromic AVRT pattern associated with that. But that also usually generates rates faster than 250, and a ventricular origin is unlikely to present at rates faster than 250. Down in the precordial leads, we still have the fusion beats and the AV dissociation. Favoring ventricular, we still have the heart rate of 250, favoring a supraventricular origin. But in the V leads, the precordial leads, you have on there negative and positive concordance. So a lot of people talk about concordance, and they're talking about concordant or disconcordant ST segments and T waves associated with wide complex rhythms and Scarbosa's criteria and stuff like that. That's not what we're talking about here. What we're talking about is something specific called precordial concordance. And when I talk about precordial concordance, what I'm talking about is when V1 is down, V2 is down, V3 is down, V4 is down, V5 is down, V6 is down, that's negative. All 6 V leads are downwards, that's negative precordial concordance. That favors VTAC. If all 6 V leads, without variation, not 5 of 6, but if all 6 V leads are positive, V1, V2, V3, V4, V5, V6 are all positive QRSs, that's positive concordance, and that favors VTAC. The absence of concordance can be either. So when V1 is down and V6 is up, that can be either ventricular or supraventricular, and that's unhelpful to you in your differentiation. So that's what I'm talking about with this precordial concordance, which is different than ST segment and T wave concordance. That's the morphology criteria for Brugada. Moving on, in 2003, the American College of Cardiology came up with this algorithm. Good luck memorizing this and recalling it 6 months from now at 3 in the morning. But one of the things I want to call your attention to is right in the middle here, and I'm going to pull that up, circle it. What it says right in the middle there is a previous myocardial infarction or structural heart disease. If yes, VTAC is more likely. So if the patient's had a MI or structural heart disease, both of which can cause scar tissue, that scar tissue can end up generating ventricular arrhythmias, and VTAC is thus more likely. Varecki has a shorter algorithm published in 2007 with 4 main questions. The problem is this fourth one is the V sub I to V sub T ratio being less than 1. Not a lot of people know what V sub I or V sub T is, and what that's measuring is the initial height or depth of the QRS complex, 0.10 seconds from the start of the QRS complex and 0.10 seconds from the back of the J point or something like that. It's something that's almost impossible to measure in the pre-hospital setting without calipers and a magnifying glass and all kinds of stuff like that. So this isn't necessarily a useful way to look at it either. So thinking through all of those Brugada algorithms and what they're looking for and the sensitivity and specificity and the morphology that are worked through with you and the American College of Cardiology parts, let's consider this patient. This is a 57-year-old male complaining of chest pain. He had an MI 10 years ago and he's got a blood pressure of 70/30. What do you think's going on here? Well, to me, I don't care. Let me be really clear with this. I don't care. This is a patient with chest pain and hypotension with a rapid, regular, wide complex tach. It doesn't matter what I name it, right? Think about this. Me working through whether or not there's AV dissociation or whether or not this looks like a right bundle branch block pattern with a R wave in V1 and a terminal S wave in 1 and V6 and all of the rest of that, it doesn't matter. This is an unstable patient. Whether it's ventricular tachycardia or SVT, what does this patient need? Hopefully your answer is synchronized cardioversion. So when do I apply these wide complex tachycardia differentiation rules? Well, first of all, it's never in front of a patient. The sicker the patient, the less likely I am to think about any of these things, right? I have a list of priorities and a list of things I need to do, and one of them isn't sitting down and argue with my partner about whether or not that's a slur of the downstroke of the R wave in V1 that counts as a rabbit ear or not, and quit doing that. If it's a regular wide complex tachycardia, treat it like a regular wide complex tachycardia and move on with your life. Move into your protocols, move into your ACLS algorithm. Quit trying to differentiate this in front of a patient. I'm giving you permission not to do something. The reasons behind that are, even if you get it right, no one believes you. The treatments work on both. Electricity is going to work on SVT, whether it's AV-NRT or AV-RT or pre-existing bundle branch block or VTAC or all of those things. Electricity works. Amiodarone probably works on both. And adenosine can even work on certain ventricular tachycardias. So why differentiate this if it's not going to help direct your treatment, direct your care for the patient? Even if you can remember all of this stuff, and even if you can recall it at 3 in the morning in front of a patient, it's still low percentage. It's still not like putting an ultrasound on someone and seeing if some finding exists. We're still interpreting the electrical impulses running through an EKG and being put on a piece of paper. It's still not affecting the patient. The sicker the patient is, the more busy you are, right? You holding a EKG up really close to your nose and trying to differentiate what's going on isn't a helpful option. Prioritize your time. And it's all too hard to remember. I have taught this stuff for 15 years. And this is one of the points where I have to have that big chart of the morphology up on the board in order to be able to talk through it. Like I could probably get 90% of it, but 90% of it doesn't help me. I have to be able to apply every rule and every algorithm and every single criteria associated with it. Picking out the one or two that I can remember isn't helping me. Like everyone knows about a taller left rabbit ear favors VTAC. Okay, it being a wide complex TAC favors VTAC, right? 80% of the time it's VTAC. So you're wasting time confirming VTAC? Treat all regular wide complex tachycardias as a regular wide complex tachycardia. Are they unstable? Shock them. Are they stable? Give them amiodarone. Move on with your life. Move on with your patient care. Just don't do it. Just don't. So I'm going to give you 6 reasons or 6 times where you can differentiate wide complex tacs. Amazingly, they're the same 6 things where I used to tell my 5-year-old I would leave her at home alone. Never, 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 never. Those are the first 5. The last one is, after the call, when you're cleaned up, when you're ready for the next call, and you feel like starting a fight with your partner for no reason. Those are the 6 times. Don't differentiate wide complex tacs. It is the path to failure for paramedics. It's actually the path to failure for all providers. Most ED physicians won't screw with this. This is a patient in regular wide complex TAC. Let's fix that. It doesn't matter what its name is. Move on with your life. Move on with your patient care. Let me know if you agree or disagree down in the comments. I always appreciate your thoughts on that kind of thing. And make sure to like, subscribe, share. Getting our point of view out in front of more people is always helpful. And I'm counting on you to help us out with that. Once again, this is Angry Bill for Pre-Hospital Wisdom. I appreciate your time. Thank you very much, and until next time, stay safe.